Carolina. Dr. Stevens is truly one of the nicest people I've ever met, and we are so honored to have you with us today. I'm going to go ahead and turn it over to you now, Dr. Stevens.
Thank you so much for the kind introduction, and I appreciate all of you that are joining today. This is a great opportunity to learn a lot of knowledge about treatment options for CLL. I tried to keep my presentation to be brief and provide a big overview, and so we can get down to some more specific questions after the presentation. But as Dalton mentioned, we welcome you to go ahead and type in questions as they come up into the chat. And as soon as I'm done with my presentation, we'll dive into those questions. And so, again, thanks so much for joining today. I know a lot of you are probably at different places in your CLL journey. Maybe some of you have just found out about the diagnosis. Maybe some of you have actually underwent treatment already. And so, like I said, I kind of wanted to provide just a big, wide overview of what the treatment landscape looks like for CLL. I'll talk about some specific and important drugs that are very pertinent for today's management of CLL. And then, like I said, happy to answer questions about any of this. So let me go ahead and show you the overview of my presentation. I'm going to give just an overview of why we treat CLL and the different treatment types. I want to look into current CLL treatment options, spend a few minutes talking about new CLL treatment approaches, and then, of course, the question and answer session. So first, the CLL treatment overview. You all are likely familiar that this is a unique subtype of cancer that doesn't always need to be treated right at diagnosis. And so often people say, why am I not being treated? Or when would I know if I need to be treated? And so I wanted to cover that. When should CLL or SLL be treated? I consider these things that are listed to be active disease. And so if you come in with anemia, which is typically a hemoglobin of less than 11, or platelets that are low, platelets less than 100, or your doctor can see kind of a progressive decline over time. That might be an indication to treat CLL. If you have symptoms from big spleen or lymph nodes, that could be an indication for treatment. And we often talk about these B-type symptoms, which is unplanned weight loss. And that's a significant amount of weight loss, greater than 10% in the last 6 months, or fevers without infection, drenching night sweats without infection again, and severe fatigue. Fatigue is a little bit of a tough one because almost everyone with CLL has some level of fatigue. And there are also, of course, other things that can cause fatigue. And so trying to sort out if the only symptom you have is fatigue, trying to sort out if that's really from CLL or from something else is important before treatment is initiated. And so these are reasons why we might want to start CLL treatment. And then, so what happens to the folks who are not doing treatment? We call this watch and wait or active surveillance observation. Some people say watch and worry because it makes them a little bit nervous to do treatment or not to do treatment and observe it. But the main point I want to show is that no treatment, at least at this point, has been proven to lengthen survival by given early. The good news for folks that have CLL is our treatments are so good these days that majority of people, we can say you are going to live a normal lifespan. And we don't have to do early treatment in order to say that. Just note, and as Dalton mentioned, I'm really interested in this area, and I do chair an ongoing clinical trial called the Evolve CLL trial. And so if you have high-risk disease, and we can talk about that later if anyone has any questions, and have been diagnosed within the last 18 months, you might qualify for this study that looks at early intervention with some of these newer treatment options. So also important to understand when we're talking about treatment, what are the goals of CLL treatment? And unfortunately, I can't yet say that we have a cure for CLL. There might be a rare case of CLL that would be cured with a bone marrow transplant, but most people don't need to have a bone marrow transplant or maybe might not even be a candidate for one. So our goal, since it's at least at this point, we know we're not curing people with the majority of these treatments, our main goal is remission. And basically, we're trying to take away those active CLL symptoms for the longest time possible. So, getting rid of anemia, getting rid of low platelets, getting rid of any of those symptoms that are related to CLL. And so your doctors may use some of these terms. We talk about complete remission. That means you've got totally normal blood counts, normal size lymph nodes and spleen. If you have progressive disease, you're going to have new areas or worsening areas of disease. If you have stable disease, there's no change. And somewhere in the middle is that partial remission. So maybe you've had a 50% reduction of those things, and we can call partial remission. So I wanted to add a slide here because I know some people might have a question about, they've probably heard about MRD or minimal residual disease. Some people call it measurable residual disease. These are very specific tests that are designed to detect tiny amounts of CLL. So maybe we can't see any enlarged lymph nodes. We have a normal white blood cell count, but we might be able to detect small amounts of CLL still. So this can be done by a test called flow cytometry, which there's a graphic over on the right-hand side that's kind of a very simplistic graphic describing what happens. You're basically just sorting these cells, or there's some genetic sequencing. And some people say MRD negative. I'd like to say MRD undetectable, but it means we can't detect disease. That doesn't mean it's not there. It's just we can't detect it to the level at which our tests can detect. I mean, we can get pretty low levels. However, sometimes we know it's still there. We just can't detect it. So some of the treatments I'm going to talk about, really the goal is to get undetectable MRD. And some of the treatments, it doesn't actually matter that much if there's still detectable residual disease. So thinking about current treatment options, this is really broad overview because, if you've known people that have other types of cancer, CLL is treated much differently. CLL cannot be treated by surgery just because, it flows throughout the body. It goes everywhere the blood goes. And so there's no way to effectively surgically cut all of it out. And similarly, radiation is not usually an option just because there's too many areas. Now, in rare cases, we might say one specific thing is causing symptoms and we can do radiation on it, but that's not an overall treatment of CLL. And so we think of chemotherapy, which is the typical choice because it's a blood cancer and these medications go into the blood and they treat all of everything the blood touches. And so I'm going to talk about classic immunotherapy and targeted therapy. So classic chemotherapy, thankfully, we actually don't use very much of this anymore. This is actually non-specific killing of growing cells. And the drugs that I put into this category are drugs like fludarabine, cyclophosphamide, bendamustine, pentostatin, chlorambucil. They can have a lot of short-term side effects. And because of that and because of the long-term side effects, which is potentially causing some damage to the bone marrow, we don't actually need to use these drugs anymore. There have been multiple clinical trials now that pit some of these drugs against our newer drugs. And the good news is the newer drugs have fewer side effects. They last longer, the remissions last longer, and actually survival lasts longer. And so when people just kind of put it into the basket of chemotherapy, we think about, maybe you've known somebody that's had breast cancer or lung cancer. These treatments are very different. So immunotherapy is a big part. These are usually drugs that are going to specifically target something that lives on the outside of a CLL cell. So they look like, kind of a graphic would be this little Y-shaped thing. And basically the top part recognizes the cancer and the bottom part tells other immune cells to kill it. So it's just a way of tricking our immune system into killing those CLL cells. The most common ones that we use are antibodies to something called CD20, which lives on the surface of a CLL cell. Most common ones we use now are drugs called rituximab or obinutuzumab. So the big deal here is targeted therapy. This comprises the biggest group of drugs that we're using right now to treat CLL. The point of these drugs and why we call them targeted therapy is because unlike those standard chemotherapy drugs that we used to use in the past, these drugs avoid killing the normal cells and go straight after the cancer cells. And so these are drugs like ibrutinib acalabrutinib, zanubrutinib, pirtobrutinib, idelalisib, or venetoclax. And there's multiple other of these drugs in development. But just as kind of a general overview of what these drugs do, so a big class and a very important class is something called a BTK inhibitor, a Bruton tyrosine kinase inhibitor. Basically, what these drugs do is they block survival signals to the CLL cells. So this is called the B cell receptor signaling pathway, and I like to think of it like taking the gas out of your car. The drugs ibrutinib, acalabrutinib, and zanubrutinib, these are all oral drugs, so these are pill, and they are approved for all patients with CLL. And then the newest of this class is called pirtobrutinib, and this is approved for most patients with CLL. So these patients have to have at least one prior therapy. It was originally approved after 2 prior treatments, and it just recently has gained approval after 1 prior therapy. So if you've had one of these other drugs, ibrutinib, acalabrutinib, and zanubrutinib, and it stopped working, it's now approved in that setting as well. Venetoclax works a little bit differently than the ones that I've talked about. It is something called a BCL2 inhibitor, and this is also a pill. But what happens is the CLL cells are going to express this thing called BCL2, and that's what helps them try to live forever. So these cancer cells want to live forever, and so when you block that signal, it promotes cancer cell death. And so basically, you're just reminding the drug or these cells that they need to die. And it's really highly effective for CLL. It's actually approved for all patients with CLL. It is approved in combination with some of those antibodies that I talked about, and actually approved as a single agent as well. So, the title of this presentation talked a lot about continuous versus fixed duration therapies or time-limited therapies. And so, when we talk about treating someone, and this can be applied to the first-line setting or even the second-line setting, we're talking about, do we want to go for a continuous therapy, meaning we are going to take this drug until it stops working, or, it causes side effects, or maybe something else better comes along. But these are long-term therapies. So we're kind of treating CLL like you would be treating high blood pressure or, diabetes by taking a medication. And so all of those drugs that I mentioned, the BTK inhibitors, are continuous therapy. And so the goal of this is to control the disease. It does result in really actually very fast responses and prolonged remission, but often you will still be able to detect CLL. So it doesn't usually achieve that undetectable MRD that I mentioned. However, it still works fantastically well. And so, the main goal of this particular kind of treatment is not to get, it's great if we get undetectable MRD, but even if we don't, we often have very great benefit to patients. On the other hand, we have fixed duration or time limited. And this basically means that when we start the treatment, we know when we're going to end it. So all of these come in set regimens. So there's, for example, just in frontline therapy, there's a regimen that is called venetoclax and obinutuzumab, which is the CD20 monoclonal antibody. That treatment is given for 12 months, and then we stop. There's a lot of new treatments coming forward that combine the pills, the BTK inhibitors, with the BCL2 inhibitor. Right now, venetoclax is the only one that is commercially available. And then maybe they also add a third drug, a CD20 monoclonal antibody. So in contrast to those continuous therapies, the goal of this kind of therapy is disease elimination and deepest response possible to try to result in a prolonged remission and time off of therapy. And we know that, not everyone can achieve undetectable MRD with these kinds of treatments, but if you do, the remissions are typically much longer. And so that's definitely a desirable effect of these kind of fixed duration therapies. And so I want to highlight some of these new treatment approaches because a lot of these, there's many clinical trials that are coming out right now. And so there's many different options of these combination therapies. So basically what we have done in this field is we have a lot of great drugs. And so we're trying to figure out, which combination is the best. And, do we need 2 drugs? Do we need 3 drugs? And we don't have all the answers to that yet, but we certainly have a lot of really effective regimens. And so kind of how this works is, we will often choose a BTK inhibitor, which I've listed those again here. You add a BCL2 inhibitor, and venetoclax is the one that's approved. Sonrotoclax is kind of a next generation one that is not yet approved, but it's getting quite close to being commercially available. And then a CD20 monoclonal antibody. Most commonly, we'll be using obinutuzumab, it's a little bit stronger antibody for CLL. And so the advantages to doing these things is maybe could we use all of our great drugs that we have and use them in a shorter, time-limited period so that we can have time off of drug. So we want to have deeper, longer-lasting responses. We want to shorten the treatment length. And so I want to just highlight a couple of examples of ongoing clinical trials to give you an idea what kind of combinations are out there. So this Captivate trial, it looks at a BTK inhibitor, ibrutinib, plus a BCL2 inhibitor, venetoclax. This clinical trial and others like it have got this regimen approved in Europe and Canada. So now, interestingly, this regimen has not been approved in the United States, and that's just because the thought is that the toxicity of the two of them together is not desirable, meaning they think that's just a little bit too many side effects with these drugs. And we also have some next generation drugs that are coming with fewer side effects. So the Celestial trial is another BTK inhibitor called zanubrutinib, and this is paired with that BCL2 inhibitor that's not quite approved yet, sonrotoclax. Both of these are pills. We don't have the full data from this, but we have lots of preliminary data from other clinical trials that look like this is a pretty effective combination. We have the Amplify study, which uses a BTK inhibitor called acalabrutinib combined with venetoclax. And in some patients, it was actually also combined with obinutuzumab. And this regimen looked quite good. And so this actually gained approval recently in the United States. And so this can be prescribed. It's available commercially. And then the most recent one, this is actually a little bit different than the other studies. The first studies that I mentioned, this is in the frontline setting. This Bruin 322 study was just presented at a big meeting called the European Hematology Association in 2026. That it's a new combination, and it's actually for the relapse setting, meaning the CLL has already had some other drug, and now it has relapsed and needs treatment again. And so this is pirtobrutinib, that newer BTK inhibitor, plus venetoclax, plus rituximab. And this is, we're still awaiting final data, but at least the preliminary data that we've seen look really good. And there's probably going to be a move toward trying to get this approved in the second line setting. So I just wanted to tease out a couple of the features of CLL treatments that I think are maybe positives and negatives. And, some people might have different opinions about whether it's positive or negative, and that's okay. I just wanted to try to make it as simple as possible. But this is specifically for the continuous therapies, and that's, again, these BTK inhibitors that we just take until disease progression. The positive for this is it's all pills, so there's no infusions associated with this. There's really limited clinic visit and very limited lab blood draws. And so if you were somebody that said, I just want to take my medication, I don't want to go in for infusions, I don't want to have many blood draws, this is a great regimen for you. Some of the negatives might be, it is a continuous treatment. And so if you're having side effects, some of the side effects with these drugs actually go away the longer you're on the drug, but some of them actually come up the longer that you're on the drug. And so there can be some long-term side effects associated with continuous treatment. And then, of course, none of these drugs are free unless you're getting them as a part of a clinical trial. And so, over time, you can develop a little bit more cost with these. So time-limited treatments, and this one is specifically pertains to venetoclax and obinutuzumab, and obinutuzumab is that intravenous monoclonal antibody. A positive to this is that in the frontline setting, it's only 12 months. In subsequent lines of therapy, it's 24 months. There's a ton of clinical trial data to support the use. And so if you want to ask your doctor, hey, I have this risk factor or that risk factor for CLL, what do you expect? What can you predict? How long will I be off of therapy after getting this? We have a ton of data now. And so that's, while not perfect, it's easier to predict those sort of things. It definitely results in deep remissions, which is great. So on the other hand, the negatives. So obinutuzumab is an intravenous infusion. And so you do have to go in for infusion. During those infusions, you might have an infusion reaction. And so that potentially could be a downside to this. Thankfully, those infusion reactions don't usually last very long, but they can be severe if they happen. It does require very frequent clinic visits. And so during the first 2 months of this treatment, you have to be in the clinic or infusion suite every week for 2 months. Once that 2 months has passed, it gets a lot easier. It separates out to just once a month until you hit 6 months, and then you can separate out your visits a lot more. One side effect is that, especially with the obinutuzumab, this does decrease your response to vaccines, and most of you probably know that you're at a higher risk of infection. So if you can't respond to vaccines, that might put you at even a little bit higher risk of infection. The features of the other time-limited treatments that I talked about, and this is the pill combination of BCL2 plus BTK inhibitors. On the positive side, it is, again, time limited. It's usually a little over a year of treatment. We don't have quite as much data yet in the second and third line of therapy, and so we don't know quite as well how to use these in the second line, but front line we have a lot of data now. They often can cause deep remissions. They don't require any infusions. And you're using good treatments. And some people said, well, if we use both of them up front, what do we use when the CLL relapses? And the good thing is that when we use it in this time-limited manner, usually we could use, maybe we just start you on both of them again, or you could get started on just the BTK inhibitor or a BCL2 inhibitor combination. So those are the positives, but the negatives of this potential combination is you still do have some frequent lab draws, no infusions, but there's usually, depending on the regimen, you usually have to go in once a week for 1 to 2 months for more frequent lab draws. And in comparison to using them separately, there's typically at least a little bit more side effects when you use them both together. So, you kind of add the side effects of one to the side effects of the other. So it comes up with more side effects when you use them together. So I just wanted to review what we've talked about. Again, this is kind of a broad sweeping overview, and I'm very happy to answer more specific questions, but I wanted to give you all time to ask some questions. And so I am going to unshare my screen and get you back to Dalton.
That was so informative, Dr. Stevens. It's incredible just seeing all the work that's being done in this space and truly how far it's come. I've been away from the CLL space a little bit over the last year, and just how far it's progressed even now is just incredible. So thank you to yourself, but also all of the CLL specialists that are doing this work. I did want to let everyone know here as they're collecting their questions that we do have a survey running right now on HealthTree's website for fixed versus continuous CLL therapy. What matters most to you? This was actually created in collaboration with Dr. Stevens. So it's a wonderful survey where patients can really provide their insights into fixed and continuous duration therapy, why they might prefer one over the other. So I highly recommend that everyone check this survey out. It is very well done, and we're looking forward to getting the results of that. So, with that being said, we are now in our Q&A section of today's presentation. So please feel free to drop your questions into the chat, and we'll go ahead and hop in here. The first question I see is from an individual that says, I have polycythemia vera as well as CLL. Is there a connection between these diseases? What are the recommended treatments?
I think this is a great question, and it's such a great question that I actually do some research in this topic. And I think the answer is I'm not sure yet, but there's a lot of work going on in this space. And there's some theory, and polycythemia vera is kind of a red blood cell disorder, and of course CLL is a white blood cell disorder. But when you're really making your own blood cells, they start as this stem cell. And so sometimes I feel that stem cells get a mutation, and that mutation down the road can end up, when the cells split off into what they're supposed to be, can end up causing two different blood problems. And so, there's a lot of research. We've done a lot of work with another kind of blood proliferation problem, which is what polycythemia vera is, called chronic myelomonocytic leukemia. And we've actually found some common mutations between those two. Um, so one thing that's interesting about polycythemia vera is that it usually causes you to make additional red blood cells. And so, as you guys probably know, CLL can cause anemia or a reduction in red blood cells. And so sometimes when people end up needing treatment for CLL, we treat the CLL, and all of a sudden we find out there's a problem with their red blood cells. Because maybe what was happening is the CLL was making the red blood cells go down, and the polycythemia vera was making the red blood cells go up. So they actually kind of ended up in the normal range. But then if we take away one thing, so the CLL, sometimes the red blood cells just start, we notice that there's a ton of red blood cells. And so there's no specific treatments that are for both CLL and polycythemia vera. However, interestingly, there's a class of drugs called JAK2 inhibitors, and those are mainly used for polycythemia vera, and they've actually been trialed in CLL as a way to reduce the side effects of CLL. So that fatigue that people get and the enlarged spleen, that those JAK2 medications can actually be pretty effective of that in patients with CLL. And so somebody with polycythemia vera that's taking a JAK2 inhibitor might actually have some relief of their CLL-related symptoms. And so it's complicated. I don't know that I've fully answered your question, but I think it's a good one, and there's still a lot of data that's ongoing that we need to help answer that question.
Yeah, the link between the two is really interesting and exciting to hear that it is being evaluated a little bit more thoroughly now. Next question up is, what problem does skin cancer cause with CLL treatments?
Skin cancer is a tough one for folks that have CLL, because it really can get a lot more aggressive just in general when you have CLL. And so that's why I generally recommend that everybody with CLL has a dermatologist, and they're being checked at least once a year for any precancerous lesions that might turn into skin cancer. Um, because what happens is skin cancer can be linked to immune suppression. And so, of course, you guys probably know that CLL causes immune suppression. And so sometimes when your immune system isn't working well, it can't, locate those precancerous skin lesions and eliminate them before they become skin cancer. And so it's people with CLL are more likely to get skin cancer. They're more likely to be more severe with more severe skin cancer. I mean, a lot of people you hear maybe talk about, oh, I had a little skin cancer, I just got it removed. For example, I saw, I have people in my clinic that have had skin cancer lesions that are, softball size. I mean, they're huge because they can spread so quickly when the immune system is reduced. And so sometimes when CLL treatment, sometimes usually at the beginning of CLL treatment, the immune system can be lowered. And this happened really significantly back when we were using those non-specific chemo treatments. The immune system gets lowered more, and the skin cancer can kind of grow faster. And so a CLL treatment might cause the skin cancer to worsen. And so that's why, again, I think, if you can identify them and remove them, even better before you start it. But I think I think we can do a lot better. I feel like you guys are like planted here because that's also an area of my research. I'm really interested in what can we do to prevent skin cancer in folks with CLL because, it's one thing to say, yeah, get it cut off, great. But if we could prevent it before it even happens, I think that would be really much better for folks with CLL.
I think that more speaks to the amount that you're involved in CLL research. Truly, we're so honored to have you with us today. Our next question up is the recently FDA approved all tablet acalabrutinib and venetoclax fixed duration therapy. Do you know if this will be covered by typical Part D drug plans? I have a popular plan, and customer service have understandably not heard of it as it's been so recently approved.
Um, this is a great question, and I like that you said a typical Part D drug plan because I have found that nothing is typical about Medicare. They're all very different, and so, I'm going to answer in general, but it will be really important that you confirm with your specific plan. And it sounds like you tried to, and they didn't know about it, but. Yes, it should be covered. And the reason being is it has been FDA approved for marketing in this space. The other important piece is it has been added to the NCCN guidelines, which are what Medicare uses to determine if they're going to pay for specific treatments. Now, having it approved by your insurance is not the same as how much does it cost you out of pocket. Because your insurance company can say, sure, I approve it, but your copay is $5,000 a month. So that's what can be a little bit different. But the good news is some of the legislature that's been passed in the last few years has really made an effort to cut down on the cost that you pay out of pocket for these drugs. And so there should be a cap on all Medicare plans at $2,000 for the year. So if you've already filled the prescription and paid $2,000, then you shouldn't be charged additional amount during that calendar year. And I know $2,000 still sounds like a lot. So most times we can actually apply for grant programs to get that copay covered as well. And so that's something, your oncologist office should be able to pay for those things. And so, usually what I will do is I'll say, we'll authorize it, which means will your insurance approve it? And if the insurance approves it, then we can kind of get down to the specifics. We can send a test claim and we can say, this is how much the out-of-pocket cost is. If it's a lot, we can go back to our medication techs and say, hey, can you find if there's any programs that might help to cover this copay? And so it's a little bit long, and some people might say, oh, it's just a pill, so let's just prescribe it. And we start it like next week. It's usually really not that smooth, and it takes, a few weeks to sometimes a month to actually get the drugs approved and to understand what the copay is going to be. This gets even a little bit more complicated because it's a 2-pill medication. So a lot of our, like let's say we were giving, obinutuzumab and venetoclax, we would go through the approval process just with venetoclax because the intravenous therapies, as long as they're approved and on NCCN guidelines, Medicare will approve it. So you don't have to really do any prior authorization for that. So anyway, I guess that's a very long-winded explanation to say it's complicated. And usually the way you can really figure it out is if your doctor gets it authorized and sends a test claim to the pharmacy, and then they'll be able to tell you exactly how much it costs. Most oncologists are going to have some sort of financial counselor, pharmacy tech, or somebody that can help to kind of sort out these details. I'll just put in a really small plug for participating in clinical trials because the cool thing about clinical trials is a lot of these are studying these kind of regimens. They're just, comparing it to something else. And if you enroll in a clinical trial, usually the drugs are totally paid for by the study. And so if it's a good trial and you can talk with your doctor about, making sure it's a good trial for you, sometimes participating in trials can have a great benefit because the medications will get covered.
Absolutely, and very well said. Clinical trials offer so many benefits that patients may not realize. So I always encourage people to speak with their physician to see if a clinical trial might be right for them because it does have a lot of potential benefits. And for anyone curious to know more about the financial aspect of living with CLL or other blood cancers, I wanted to let you all know that HealthTree does offer monthly webinars with a financial advisor that really dives into some of these financial questions. I know that she'll do a dedicated Medicare topic probably in the coming months. So be on the lookout for that. She's wonderful and very informative. Our next question up is a 21 centimeter spleen dangerous and need to be treated? This individual's white blood cell counts are 96,000 and platelets are 61. They are having some night sweats. So think beyond this, just kind of when is the right time to start having a conversation about starting treatment?
Mhm. Yeah, and again, this is very individualized, and so a lot of it depends on the trends of these things. For example, you mentioned the platelets of 61, and that is less than 100,000, which is what we usually say is our cutoff for when we're going to start thinking about treating CLL. However, you can get something called ITP, which basically means your immune system is breaking down your platelets, kind of treating them like they're bacteria. And if somebody has platelets of 61, but they've been 61 for like, 6 or 7 months, you may actually not, you could do treatment, but you may actually not have to do treatment right away. Um, the total white blood cell count, I often don't, there's no cutoff for me of when I treat it because sometimes people can have a ton of symptoms and they only have a white count of 20,000, and some people can have a white blood cell count of 250,000 and they
He's
feel
answering my
fine.
question.
And so, I'm so sorry, did I?
Go ahead.
Okay. And so, it depends on how you're feeling with that. So a white blood cell count of 96,000 and you still feel great, you might be able to wait a little bit longer for treatment. But if that white blood cell count was 30,000 3 months ago, so it's really been skyrocketing up from 30,000 to 96,000, we calculate something called a lymphocyte doubling time. And if the amount of time it takes for it to double is less than 6 months, that might be an indication to treat CLL. Mild night sweats, I wouldn't necessarily recommend treatment for that. I usually think of drenching night sweats. And then a 21 centimeter spleen, again, that depends a little bit on the individual, because if you are a very small individual, 21 centimeters might be quite a big spleen. If you're a larger individual, that might mean it's hanging a little bit below your ribs, but not totally. And usually with CLL, we're not worried that they're going to spontaneously rupture the spleen because CLL doesn't grow really fast. And so it's not like it's growing fast and it's just going to burst. However, if it is big enough, which 21 centimeters would be big enough to hang below the ribs, and the ribs are there to protect your spleen. And let's say you get in a car accident or you're playing tackle football and you get an injury to the spleen. Yes, yes, it can be ruptured. Day-to-day basis, normal stuff, it shouldn't spontaneously rupture. But a lot of the things you're describing, so pretty big spleen, especially if you have symptoms, if you have abdominal pain related to it, or you're not able to eat large meals, you're losing weight, plus a platelet count of 61. There's a lot of things there that might indicate need for treatment. And I'm not being very definitive here, but again, just because that depends on the individual and is worth talking with your doctor about.
Absolutely. And I think CLL is so unique in a lot of different ways, but one of them is the watch and wait aspect, but also patients' input when it comes to different therapies and treatments that are right for them. I just wanted to know if you have any insights on how patients should approach those conversations with their treating physician on either when to start treatment or trying to figure out what the best treatment option may be for them.
Yeah, great question. There's so many options that it does take a while to kind of go through them. And so it's good if your doctor has a little bit of time to speak with you about these things. I think the biggest thing to me is I want to know, what is your day-to-day quality of life like? If you are going about your day, doing all the things you normally would do and, out living your life, that's great. And I don't want to start you on a treatment that is going to give you side effects when you're already feeling great. But if you come in and you say, you know what, I love babysitting my grandkids and I just can't do it anymore because I'm so tired. I have to take a nap and it just being with them doesn't allow me to do that and I just can't do it anymore. Or, I will give the example of my husband. He loves to golf and I know anything that makes him feel bad enough not to golf must be pretty serious and needs to be fixed. So just think of that. Anything that you really like to do, if you just feel like you don't have the energy to do it or your CLL is keeping you from that, I think that's very important information for your doctor to know, because those kind of things, when people tell me those kind of things, it makes me want to treat the CLL, because I'll trade off maybe having some side effects with the treatment to make them feel a lot better and take away those side effects you get with CLL. And so I think really, describing to the doctor what your day-to-day life is like, and if you feel like your day-to-day life would be better with treating the CLL, that might be a time to do it. I think, the people who are already here are probably, well ahead of the curve. You're already researching different kinds of treatments. And so you're going to be able to have a very smart and educated conversation with your doctor about these things. I think, if you're talking about treatment and they say, hey, this is the option, we're going to do it. I've just told you how many different options there are. And so if you don't like that option, I don't want you to be shy about saying, well, hey, what are the other options? Or, I don't really want to do continuous therapy. Could I do something that's a shorter treatment? And so again, I think, this group is probably well equipped to ask all of those questions.
Yeah. Next question that just came in is, are off-label drugs considered? NPR has dismissed claims of a small study of ivermectin plus another drug does something.
Um, Off-label drugs are definitely considered in the treatment. I think it depends on the off-label drug, though. So, for example, I try to use something that has a lot of data specifically for CLL. And what I mean by a lot of data, I mean these drugs have gone through phase 1 trials, which means we know that it's safe for people with CLL. They've gone through phase 2 trials, which just, we've got a lot of patients here and we can see really good results. Meaning, whatever result you're looking for. Is it time of long remission? Is it improved like time of survival? Whatever. As long as we're seeing some improved results. And then what happens is drugs go into phase 3 study, which means we take one of our standard treatments, so things that I've talked about today, and we compare it to this new treatment, and we give you an idea which is better. And I mean, it might be better for multiple reasons. Like, does it work better? Does it have fewer side effects? Whatever. And I think, the example of ivermectin, I hear this question a lot, and I'm not saying there's no use of it here, but it just hasn't been studied to that level in folks with CLL. And so that wouldn't be something that I would recommend as off-label. And let me back up and say, what do we mean off-label? It means a drug that has already been approved for something else, not CLL. Could I prescribe that for CLL? And in general, things within reason, your doctor has to have some good scientific support that they can give to your insurance company, or else it won't be approved. And so, I haven't got ivermectin approved for anybody, but like, for example, I mentioned the drug pirtobrutinib. So this is a drug that's approved in the second line and third line setting for CLL. So we have a ton of data in CLL. We actually have already even seen phase 3 studies in the frontline setting for CLL, but it is not approved in the frontline setting. So an off-label use might be, well, hey, there's a specific reason why I think it would be better to give pirtobrutinib in the frontline setting, even though that's not where it's approved, but it's approved for other cases of CLL. that's when I use off-label drugs. Or, for example, there's a class of drugs called bispecific antibodies. There's one called epcoritamab that has a lot of data in CLL. It has not been approved for CLL, but it's been approved for a different kind of lymphoma called diffuse large B-cell lymphoma. And so if I'm in a situation where I truly think that that's the best treatment for my patient, I will try to get it off label. So I think it's a good question. And I think to me, it's about the amount of data, and I need safety data. I need efficacy, or how well does it work data. And I need to know how well does it compare to the other great drugs we already have. And so, it doesn't mean, and a drug, maybe it just hasn't gone through all of those trials yet. It doesn't mean it couldn't have that level of proof later. But if it doesn't have that level of proof now, I'm not doing it off label. And but would I consider doing some sort of clinical trial to understand if it is a good treatment? Certainly.
So, and then you said something there that I just want to get some clarification for the audience because it's a conversation that comes up pretty frequently. But CLL, is it leukemia or is it lymphoma or is it both? Because people hear chronic lymphocytic leukemia and they think leukemia, but you just referred to it as lymphoma. So just some clarification there.
That is a great question and does come up all the time. I actually there's two, we talk about CLL and we talk about SLL. So CLL is chronic lymphocytic leukemia. SLL is small lymphocytic lymphoma. When you look at these cancer cells underneath the microscope and when you do tests on them, these cells look exactly the same. And so I think it's a very confusing term to say something is leukemia and something is lymphoma. And so CLL is just this unique type of leukemia that behaves a lot more like lymphoma. And that's because the kind of blood cells that cause both of these cancers are white blood cells called lymphocytes. And so what happens is something mutates in a lymphocyte, which is a normal blood cell, and it starts growing more than usual. And where leukemia, the name leuk means white blood cell, emia means in the blood, CLL is a lot more frequently found circulating around in the blood. And so it's kind of like a lymphoma that circulates in the blood, and so that's why it's called a leukemia. I try to avoid using the term SLL, even though there is a specific diagnosis for that. I try to refer to everything as CLL. And so I think it's really kind of in its own class. Because it's interesting, even the scientific world sometimes doesn't know what to do with it, because sometimes leukemia, CLL is kind of put clinically with people who get acute myeloid leukemia. Sometimes it's treated with people who get lymphoma. And so it's kind of in a class of its own. It's a little bit of a unique thing. Why I don't like the two separate terms is because CLL has a different staging system than SLL. And so I think it just gets really confusing to people. And I don't like the staging for SLL, because if you use the non-Hodgkin lymphoma staging, every single patient has stage 4 disease. When by the CLL staging, most of these people probably only have stage 1 disease. And so I think it creates unnecessary anxiety to use the NHL staging.
Yeah, that makes a lot of sense. So we are going to cut our questions off there just due to time, but I wanted to thank you again, Dr. Stevens. This was remarkable. All of the work that you're doing and your ability to communicate this so clearly with our audience is fantastic. So truly, thank you for everything that you do. Of
Yeah, thanks for having me here today. It's been great. Thanks for your great questions.
course. And as we're wrapping up here today, I just had a couple of things that I wanted to share. First off is that HealthTree does have a Black health community. So if you or someone you know could benefit from a Black health space, we offer that. It's a wonderful group. So please feel free to reach out to me if you'd like to get more information about this. I know that they have some Black health specific webinars and gatherings. So great space for this. So please feel free to reach out to me if you ever have any questions about it. And then we do have some upcoming events that I think the community may be interested in. So on Tuesday, July 16th, we have What to Ask Your Physician After a Diagnosis. And then on Monday, July 27th, we have a community gather event for caregivers. So if you are a caregiver or you have a caregiver that could benefit from speaking with other caregivers, this is a fantastic space to just come together, share experiences, and really talk with other caregivers who understand what it's like being a caregiver. So again, if you yourself are a caregiver or you have a caregiver that could benefit from this space, please feel free to join that. It is an amazing group. And then on Wednesday, July 29th, we have Heart Health and Blood Cancer Care, what patients and families need to know. I'm very excited about this one. This is with a cardio oncologist who is pretty active in blood cancer research and how blood cancers affect the cardiovascular system. So I think that this is one that all blood cancer patients should be aware of. So really, really excited about that event. But please feel free to check any and all of these out. We'd love to see you there. And before we go, I wanted to give one more special thank you to our CLL Central sponsor, AstraZeneca. Without their support, we can't do events like this. So, huge shout out to AstraZeneca for that. And finally, thank you for everyone for coming today. It means a lot to us that you join us, and a extra big thank you for Dr. Stevens for sharing her knowledge with our community. We're so fortunate to have specialists like yourself being willing to come on and share their time with us. If you ever have any questions, please feel free to email me. My name is Dalton at, or my email is dalton@healthtree.org. I always love hearing from the community, so please feel free to reach out. And I hope that everyone has a wonderful rest of their day.